Welcome to MS Masters, where we present expert lectures on current hot topics in clinical care for multiple sclerosis. In this episode, Scott D. Newsome, D.O., professor of neurology, Johns Hopkins University, Baltimore, Maryland, discusses how Ocrevus Zunovo can be used to treat primary progressive and relapsing forms of multiple sclerosis, including how the drug is administered, research related to the efficacy of this formulation, and the impact on clinical practice and patients.
Hello, I'm Joe Rusko, the editor-in-chief of Practical Neurology, and I'm here chatting with Dr. Newsome. So, Dr. Newsome, please tell us about your practice and your experience treating patients with MS.
Well, first off, thank you for the invite to talk with you all today. So my practice is predominantly seeing people living with MS. I would say around 80 to 90% of people that I see have either relapsing remitting MS or one of the progressive subtypes. The rest of the patients I see are sort of a potpourri of other autoimmune neurological conditions. In my practice, we use a lot of disease-modifying therapies, from the old traditional therapies or legacy therapies, as sometimes we'll refer to them as, and now more so the newer therapeutics, including the infusible therapies, and now hopefully subcutaneous ocrelizumab.
In September of this year, the FDA approved Ocrevus Zunovo for relapsing and primary progressive MS. Tell us why it's so important to have that alternative route of administration, the subcutaneous, to treat patients with these conditions.
What I like to think about as it relates to disease-modifying therapies and MS is the more potential treatment options we have, the better. The more potential routes of administration that we have, especially for medications that we would deem as high efficacy drugs, the better for our patients. And this is for a couple of different reasons. We know that MS is not a cookie cutter disease where one shoe fits all, or one size, I should say, fits all. One therapeutic route of administration may work for one person and may not work for another. And that could be related to side effects related to the route of administration. That could also relate to quieting the disease activity as it relates to the person's multiple sclerosis. When it comes to ocrelizumab specifically, what I'm most excited about is there are some people that don't have the opportunity to get the IV formulation as it stands right now. And this could be for many different reasons. One could be where they live. Maybe they're quite a distance away from an infusion center. Maybe they don't have the amount of time that it's needed to get an IV-related therapy. Where are people at? I do feel like different routes of administrations for medications will allow more people to get on a medication that could work very well with them, and specifically subcutaneous ocrelizumab.
It's important that you mentioned that because at ECTRIMS, we found even more evidence about starting therapy earlier can prevent future disability. So important point. So I'm curious about how specifically the drug is administered.
So in the clinical trials, it was administered in a couple different ways. Early stage clinical trials, like if we go back to the Ocrevus study, it initially was given via a manual administration. So a manual syringe, and still the healthcare professional standing next to the bedside and administering it through this syringe. Throughout the course of the rest of the clinical trial program, a syringe pump has been utilized to make it a little bit easier for healthcare professional and also patient. In my view, having flexibility in giving a therapy is incredibly important. Technology sometimes fails us. So let's say someone is getting their treatment via a syringe pump, and maybe the pump goes rogue and it stops working for whatever reason. You can transition over to do it manually. And so we have that experience in the clinical trial program. Also, this is not new technology. This has been done in other therapeutic arenas. But as far as ocrelizumab, of course, this is the new route of administration for ocrelizumab. I know in future we'll probably talk more about the clinical trial program itself, but I reassuringly, if you look at the clinical trial program, especially Ocarina 2, the pharmacokinetics, pharmacodynamics, and the clinical output is essentially equal when we look at IV versus subcutaneous. And just to elaborate more on that, when we look at disease activity, i.e. relapses or MRI findings, there's almost complete suppression of disease activity no matter what the person was randomized to at the start of the Ocarina 2 trial. And so I think that's important for people to take note of. There are some therapeutics that when you change the route of administration, it impacts actually the efficacy of the drug. This does not seem to be the case for ocrelizumab. And again, thinking about how this is applicable globally, having another route of administration for a high efficacy drug is really going to be able to get it out to individuals that may not otherwise be able to get a high efficacy drug like ocrelizumab IV.
So you mentioned that this new method of administration expands the options for clinicians and patients, and it could help some receive treatment earlier. Is there any other important considerations that patients should know about?
So the way the prescribing information is at this point in time, and this may be different depending on what health system you're in, but there really seems to be not a pigeonholed side of care for receiving the sub-Q therapy, which I think is going to be incredibly important over time. So what I mean by that is there may be individuals, depending on where you are getting your care, that could get this therapy maybe in doctor's office space, maybe at home, in an infusion center. There could be a hybrid. For example, there may be some places where the first treatment would be done in an infusion center, for example. And then once the clinician and the patient feel comfortable about the treatment and how well it went, it could be transitioned to a different site of care. A healthcare professional, though, does need to be involved in the administration, at least here in the US. Will that be the case over the long term? I guess we'll have to see. But I do feel like the hassle factor of the treatment is less than what some of our other treatments have associated with it. And what I mean by that is the duration of the entire treatment experience is less than our other therapies that are administered via IV, including ocrelizumab IV. So there is some pre-medication that is given to help with any infusion or injection site reactions, systemic reactions. And then the actual duration of the injection is around 10 minutes, which is incredible in terms of the convenience for our patients. And for those that have been on IV therapies of different types, this is so short compared to those other treatments. So I think it's really going to open up the doors for a lot of people who don't want to sit for a long period of time getting a treatment, and they get this treatment, which is very quick, well tolerated based on clinical trial data. Most people will have a little bit of an injection reaction, but that goes away within a couple of days based on the clinical trial data we have. Very little systemic injection reactions as well. In the clinical trial program, very few people dropped out of the clinical trial. And this, I think, speaks to how well tolerated it is. Lastly, patient satisfaction is incredibly high.
So let me just see if I got this right. For an infusion, we're talking about several hours on top of the pre-treatment protocol. But for this, it's a much shorter duration overall, even with the prophylaxis you have to take in advance. So
Correct. And here in the United States, just to make people aware, the very first injection is done where you have to have an hour post-injection monitoring. So it's a little bit longer than it will be in subsequent injections. And then subsequent injections, it's considerably less time that the person has to be monitored post-injection. But when all is said and done, we're talking less than an hour when you look at after someone's been on the treatment for a bit of time. And also what I neglected to mention before is the injection, even the very first injection, it's only one injection. So it's not split up like other infusion therapies.
Thank you for clarifying that. Appreciate that. So now, talking about the impact on clinicians, could this be an opportunity for other extenders to participate in the administration, like advanced practitioners or NPs or what have you? I'm curious about what effect this will have on daily activities of some of our audience.
Absolutely. So the prescribing information says a healthcare professional, which all those people that you just listed out fall under that. And so it certainly could be an APP, could be a nurse, could be a doctor. And I think that that's important because at least the way I envision it. And of course, this will not apply to every practice, but one could even think about it, even in a busy practice, right? Doctor's office space, where you have the person come in for their routine clinical visit. And around that visit, they could get their treatment right on that day. We do this right now for some of our therapies that require an infusion center. We'll have them come in, they'll get their treatment either before or after they see us clinically. I think that this will be an opportunity for the subcutaneous formulation, do the same thing, but in a shorter amount of time. And there will be more flexibility in terms of site of care. So that opens, as alluded to earlier, that opens the door for a lot of people to get access to a high efficacy drug, which they may not have been able to get otherwise.
It would be great to have one less appointment. That sounds efficient.
Absolutely. It's like one-stop shop, right? If you can even squeeze in like your annual MRI, get your safety labs, it's the hassle factor of treatments, the hassle factor of just healthcare in general. And so if we can make it easier for our patients and easier for our clinicians, because that's also important, and office staff, I think all around that's just going to be a win.
Excellent. Any final thoughts from your end?
Just to reiterate some of the other points, I'm excited that we have yet another treatment option for our patients living with MS and MS of different types, including primary progressive MS. A treatment option that is short in duration, that will offer the same protection in terms of preventing new problems related to MS as ocrelizumab IV, which we know works exceedingly well. And I'm excited that really globally, this will be a very important treatment option for people, not only as like switching, but this should be thought about as a first-line treatment option for individuals. And as you alluded to at ECTRIMS, there was data suggesting, and there's other studies suggesting that maybe we should consider treating people from day one with a high efficacy drug to help prevent future disability. And I think ocrelizumab subcutaneous comes into that conversation now, which is really exciting for me. And I think that clinicians should read up on the clinical trial data. Clinicians should become familiar with the prescribing information. So if there's any questions around, well, does this have to be pure cure? Does it have to be on ice? There's a lot of different things that I think are important for clinicians to learn about. And the prescribing information has all these details in there. And I could go on and on, by the way, but I'll leave it at that.
So important. Thank you for your time and your insights, Dr. Newsome. I appreciate it.
Thank you.
Thank you to Dr. Newsome for sharing his knowledge with our listeners in this episode of MS Masters. And thanks to you, our listeners. Be sure to visit theneurologyhub.com for more podcasts in the neurology field. MS Masters is brought to you by the editors of Practical Neurology.